All right. So I think we'll start. So good morning or good afternoon. Obviously, I'm not Pierre Bordachard. My name is Hugo Pierracine, and I'm a device fellow here in Bordeaux. Pierre is not here today, so he asked me to give a session on implantable cardiac monitors. So today we'll discuss the Medtronic Reveal link. So we'll briefly discuss indications, implant procedures. We'll discuss the device characteristics, recordings, and then we'll review tracings. I think it's important in your training, either general cardiology or EP, that you have at least one session on implantable cardiac monitors. So, all right. Currently, in France and in Canada, I think it's the same in the US. We're seeing more and more implantable loop recorders. I think it's gonna definitely grow in the future for different indication. So it's therefore important to know the basics of ICM and how to correctly interpret tracings. Right. So everybody can see my slides. Yeah. Okay. And feel free to stop me whenever you want. All right. So the indications for implantable cardiac monitors are pretty broad and includes patients with clinical syndromes or situations at increased risk of cardiac arrhythmias. And of course, patients who experience transient symptoms that may suggest a cardiac arrhythmia. So this include unexplained palpitation, unexplained syncope, screening for AF, etc. So if we look at the guidelines, the ESC 2018 guidelines and syncope have made a class 1 recommendation for ILR implantation for patients with unexplained syncope with high likelihood of recurrence at follow-up, for patients at low risk, and even for patients at higher risk, of course, after a comprehensive evaluation. The use of ILR for AF, there's an integration in the CCS 2020 AF guidelines for cryptogenic stroke after a follow-up, and it's the same for ACC AHA 2019, the class 2A recommendation for patients with cryptogenic stroke for the screening of AF. And of course, after implant, it is mandatory, in my opinion, to have access to a remote monitoring program to follow these patients. There are virtually no contraindications, and the insertion procedure is pretty simple and straightforward. But there are important steps that you need to know in order to avoid complications. Complications are rare but can happen and includes pain at insertion site, hematoma, device erosion, etc. There are also anecdotic complications like device migration. So here are two reports of device migration. So at the top you can see here it was a Biomonitor 3 that was implanted at the normal insertion site, and the device migrated all the way back in the pleural space. You can see it here in the back, and it was retrieved surgically. And there are also a few reports of Reveal link migration. So here you see the patient that had a link implanted, and the device migrated all the way down on his diaphragm, more than 18 centimeters from the insertion site. And of course, there are also reports of intrathoracic placement of ILR. So this image makes me lose my mind every time I see it. So here is the device. It was a Biomonitor 3 that was implanted, into the chest. So it is, even if it's a simple procedure, it is important to be properly trained in order to avoid and minimize the risk of complication. So in the next minutes, I will show you a video that Pierre made about the implant procedure. It's a video in French, but there are subtitles in English.
Les conditions d'implantation d'un moniteur cardiaque implantable ont récemment évolué en parallèle au développement de l'ambulatoire et à la miniaturisation des prothèses. Les tout premiers dispositifs étaient systématiquement implantés dans un bloc opératoire ou plus fréquemment en salle d'électrophysiologie. Aujourd'hui, ce type de dispositif, du fait de la réduction de la taille, peut également être implanté dans une salle de consultation, dans une salle de soins, même si aujourd'hui on ne travaille donc plus systématiquement dans des conditions de bloc opératoire, il est essentiel de préserver des conditions rigoureuses d'asepsie à réduire le risque d'infection. Dans les différentes vidéos qui vont suivre, je vais vous décrire pas à pas les différents temps de l'implantation d'un Reveal Link, donc un moniteur cardiaque implantable de la marque Medtronic. Rentre en salle, avant de bénéficier de l'implantation d'un moniteur cardiaque implantable, je conseille de réaliser systématiquement un dernier électrocardiogramme juste avant l'implantation, de façon à vérifier, comme chez ce patient par exemple, qui va être implanté pour AVC cryptogénique, que le patient est bien en rythme sinusal, on va voir assez distinctement les ondes de P sur le tracé, et qu'il n'est pas passé en fibrillation auriculaire juste avant l'implantation. Effectivement, si le patient est en fibrillation auriculaire au moment de l'implantation, il n'y a aucune utilité à implanter le moniteur cardiaque implantable. L'implantation se déroule évidemment dans des conditions de stérilité, donc avec un kimono stérile et des gants stériles. Puis, on va installer la table avec un champ stérile pour pouvoir ensuite déposer les différents instruments. Donc, vous pouvez voir sur la table le matériel qui va être utilisé pour cette procédure d'implantation de moniteur implantable. Donc, on peut voir que l'on aura de façon assez classique une cupule pour la bétaline, une autre cupule pour l'anesthésie locale. On aura des pinces donc pour le badigeonnage et pour réaliser la suture. On aura évidemment le fil pour suturer si c'est ce moyen-là qu'on utilise. On aura des compresses stériles, le champ stérile pour le patient, la seringue et pour l'anesthésie locale et le kit d'implantation. Et on voit que le moniteur cardiaque implantable est déjà préchargé. Et on aura également le pansement en fin de procédure. Nous allons maintenant réaliser une désinfection du site opératoire. Cette désinfection doit être réalisée sur une peau qui est propre et sèche, le patient étant rasé au préalable. Nous allons désinfecter sur une large partie du thorax, même si le site d'implantation est relativement limité, c'est important d'avoir une fenêtre relativement large de façon à éliminer le maximum de germes superficiels. Et cette désinfection peut être réalisée avec de la chlorhexidine ou de la bétaline. Une fois qu'on a réalisé 2 applications, il faudra attendre que cela sèche avant de champer le patient. Nous allons ensuite procéder au champage du patient. Donc, il s'agit d'un champ stérile et d'un champ troué. En ce qui concerne le positionnement du champ, il est essentiel de se laisser les différentes possibilités d'implantation. Et donc, on doit pouvoir avoir un champ implantatoire où on a accès à la partie gauche du sternum, quelques centimètres à gauche du sternum, au niveau du 3e, du 4e ou du 5e espace intercostal. Comme ici, on peut voir que là, on a la possibilité d'implanter le Reveal où on veut.
All right, and then the second video.
Donc, il va falloir maintenant choisir le site d'implantation, le site le plus traditionnel et le plus classique et qui donne finalement de très bons résultats chez la majorité des patients, c'est de positionner au niveau du 4e espace intercostal, à 2 cm environ de la marge latérale du sternum et avec un angle de 45 à 60 degrés. Les résultats sont généralement très satisfaisants avec cette position. Une solution alternative peut être de positionner le dispositif toujours au 4e espace intercostal, à 2 cm de la marge latérale du sternum, avec une incision qui peut se faire par le haut ou par le bas, mais cette fois avec un positionnement vertical. pour des conditions esthétiques, parfois, on choisit un positionnement sous-mammaire, particulièrement chez les femmes. Donc, on va se positionner au 5e espace intercostal. Et on va toujours avoir cet angle-là où on peut mettre aussi le dispositif perpendiculaire au sternum, de façon à le rendre le moins visible possible. Une autre option peut être privilégiée si on veut optimiser la qualité de la détection de l'oreillette, c'est de positionner le système un peu plus haut, au niveau du 3e espace intercostal. Donc, nous allons maintenant réaliser l'anesthésie donc au 4e espace intercostal, à 2 cm à gauche du sternum. J'ai choisi ici de la xylocaïne qui est action courte et qui est donc parfaitement adaptée à ce type de procédure. Dans certains centres, on associe de l'épinéphrine pour réduire le risque de saignement. Alors, il va falloir injecter doucement, de façon assez large, au-dessus et en dessous de l'incision. Plus on injecte rapidement, plus ça peut être douloureux pour le patient. Et ensuite, on va injecter à 45 degrés, de façon à injecter jusqu'au bout de l'aiguille, de façon à bien anesthésier l'intégralité de la loge du dispositif. Nous allons donc nous servir maintenant du scalpel qui est fourni avec le kit d'implantation. Nous allons pincer la peau et pousser avec le scalpel en préservant un angle 90 degrés par rapport à la peau qui a été pincée. Et donc, nous avons maintenant une incision d'1 centimètre environ. Nous allons nous saisir maintenant du dispositif d'insertion. On peut voir que le holter implantable est préchargé. Nous allons pousser le système avec un angle de 45 degrés par rapport au sternum, en essayant de rester horizontal, de façon à avoir une profondeur d'environ 8 à 10 mm. Donc, on pousse le système jusqu'au bout. À partir de là, nous allons réaliser une rotation de 180 degrés qui va permettre de faire la loge pour le futur dispositif. Puis, nous allons prendre le piston et on va pousser jusqu'au bout en calant bien les doigts, le pouce et les doigts au niveau de la peau. On va pousser le système jusqu'au bout. Il y a un clic quand le holter implantable est sorti du kit d'insertion. À partir de là, nous allons pouvoir retirer notre kit d'insertion en un temps ou en 2 temps. Et quand on le retire, on maintient bien le moniteur cardiaque implantable en place.
All right. So I think I will skip the third video, which is about closing the incision site. You can either close with sutures, surgical glue, or some people even use staples. So any questions on the video? No? All right. So the post-implant sensing, the R wave amplitude after implantation should be a minimum of 0.2 millivolts, and the peak-to-peak R wave should be at least twice the peak of the T or P wave, so whichever is greater. And if this criteria is not met, then you should reload, reposition. And when you do this, you can reuse the same incision, but just change the angle of the insertion tool. So before interpreting tracings, we will review the type of episodes the link can record. So the link continuously senses the patient's subcutaneous ECG and is looking for episodes of VT, fast VT, atrial tachycardia, atrial fibrillation, brady, and pause. So let's start with tachy episodes. So tachy episode will be stored if the device senses intervals shorter than the program tachy interval length, and that the noise level is not excessive during these episodes. You can either program a number of cycles between 5 and 48, and this you need to program also the cycle length, and it's from 270 to 520 milliseconds. So to record a tachy episode, it requires a rapid onset. So the device will compare the 4 most recent R wave intervals with the 4 previous one, and if it's above a certain cutoff, then it will be classified as a tachy episode. There is also another way to implement a tachy episode. It's a fast VT zone that it's non-programmable. So it's when you have a rate faster than 231 beats per minute and a duration of more than 30 out of 40 cycles. The tachy episode will end when one of the following criteria is met, either 8 consecutive R waves that are detected slower than the programmed tachy interval, or if the median ventricular interval is equal to or longer than the tachy interval for a period of 20 seconds, or if no R wave is detected during a period of 10 seconds. Pause. So, of course, you can program the pause parameters. So it will detect a pause or an asystole if it exceeds the program pause duration. So you can select either 1.5, 3, or 4.5 seconds. And the episode will terminate after 12 ventricular sense events have occurred. You can program the pause detection to off if you want. For Brady, so it will start when the number of R waves with a ventricular interval are longer than the program interval again. So it's either 30, 40, 50, or 60 beats per minute that you can program. And the number of intervals, it's either 4, 8, or 12. So it will end when one of the following criteria is met, either 4 consecutive R waves that are detected with an interval that is shorter than the program interval, or no R wave detected during a period of 10 seconds. And just one quick word on the nighttime ECG stored. So it's EKGs that are stored between midnight and 6 a.m. So this is something you can program on the link. So as you can imagine, the Brady episodes occur more frequently at night, and this can increase quite a lot the burden on the remote monitoring team for Brady alerts at night. So you can either select no ECG to be stored between midnight and 6 a.m. If you select that, the counter will still be implemented on the quick look tab, but you will not have an ECG available for these episodes. You can either select also 1 or up to 3 ECGs stored. For AT and AF, so the device will detect the occurrence of AF from variations in the ventricular rhythm, and it will be based on the pattern of R wave interval variability within a period of 2 minutes. So I think it's also important to know what the device will record for every episode. So for each AT and AF episode, the link will record the first 2 minutes of the episodes. For each tachy, Brady, and pause episode, you will have 30 seconds ECG available. And it will stores up to 3 episodes daily of each type. And there's a feature that the patient can activate the recording with the remote, with a remote, and he can store up to 3 patients' activated episode logs daily. So up to a total of 10 logs. And the nominal programming, when the patient activates the recording, you will have 1 minute after activation and 6 minutes 30 of ECG before activation. All right, so now let's review tracings. You can see PDF. All right, I guess it's a yes. So this is so this is just to show you the interface. It's in French, but honestly, it's not complicated. This is an episode of a normal tracing. So after every implant in Bordeaux, we ask the patient to activate recording with his remote. So this is an example of patient activated recording. So you have here the episode is labeled as symptoms, and you have here the blue line with the star that corresponds to the moment where the patient activated the recording. As I said, you have with the nominal value, you have 1 minute after the activation and 6 minutes 30 before. So you always have to look at the tracings after the graph. So if we zoom here, we have the V-sense marker at around 90 beats per minute, and we can clearly see a P wave before every QRS. So this is just an episode. This is normal sinus rhythm. It was just an example of tracing, just to show you the interface. All right, so now let's review the next tracing. It's also an episode of symptoms. It was activated by the patient, but the device also automatically recorded a pause episode. So this was a device that was implanted in a patient for recurrent syncope. So you can see at first a pretty stable heart rate, then decrease in the heart rate. Here you have no more dots and then a reacceleration, and approximately 1 minute after the patient activated the recording. So here it's the full episode. So you have here in blue, this is 10 seconds. And if you we can see in red what was automatically recorded by the device. And here you have the blue star, and it's where the patient activated the recording. So if we zoom, at first we can clearly distinct the P wave before every QRS. And then there is a gradual slowing of the heart rate, and then a long pause. We have a bit of artifact on the baseline, but we do not distinct clearly blood P wave, so it looks like a pause and then a reacceleration. So again, there was no specific context for this episode in this patient. So he had a pacemaker implanted at follow-up. All right, no questions? Okay. So this is the next tracing. It's recorded as a Brady episode by the device. So it was programmed on 4 beats and a lower limit of 30 per minute. So here, as I said, when you have the recording of an episode by the device, you will have 30 seconds of tracing. So here you can see 1, 2, 3, 4 cycles that were lower than the program limit. You have the detection. And then 1, 2, 3, 4 cycle faster, you have the end of the episode here. So let's review the tracing. So, all right. So at first here you can see P wave, V-sense, so normal sinus rhythm with a long PR. And then this is the beginning of the event. You have V-sense, B, and then another B, and then the 4 consecutive cycles labeled as B. Then you have VD's bradycardia detected. So if we zoom again, we can see here a P wave, here conducted P wave. So this is 2-to-1 AV block. And then bradycardia detected by the device. And then after a reacceleration. So these tracings are pretty simple and easy to interpret. And I think it's just to show you what information you can have on tracings. Most of the time, link tracings are not that hard to interpret, but there are sometimes can be quite tricky. So this is pretty straightforward. So I guess there is no question on this tracing. Right, I'm going to show you another tracing. So feel free to stop me if you want to jump in and volunteer in interpreting the tracings. Otherwise, I will just continue. So this is another episode of Brady recorded by the device. So at first, we can see on the graph what appears to be an alternation between faster and slower cycles, and then 1, 2, 3, 4 consecutive cycles that are slower than the program Brady rate, and then 1, 2, 3, 4, and you have 4 consecutive cycles faster, and then you have the end of the episode. So let's have a look at the tracing. So here you have vSense on the QRS, and then B, and then another marker B, and then vSense. So once again, this is pretty easy. So you have the patient's native QRS, and then you have a premature event here that is a PVC, that is under sense. So when you have 4 consecutive cycles labeled as B with PVC under sensing, the device will detect a bradycardia. So this is quite frequent PVC under sensing, but it has been improved on the Link 2 platform with smart filtering and PVC detection algorithm, but still it's a false positive that we see quite often. And we're expecting improvements with the newer platform. Hopefully on the Link 3, it will be a bit better. All right, and our tracing of pause. So here, once again, 30 seconds of recording. Here it was programmed at 3 seconds duration. So you have here an heart rate stable with decrease here and no more dot, and then slow cycles with the end of the episode here. All right. So on the tracing, we see at first clearly normal sinus rhythm, 1 P wave before every QRS, and then here 1, 2, 3. You see the EKG was interrupted here, and then you have another block P wave here, and then 2 to 1 AV block. So this is a high-grade AV block, 2 to 1 AV block. So the patient clearly had a pacemaker at follow-up. So once again, not very complicated tracing. Okay, this is another one labeled as pause. So we see before the detection of the pause, we have a pretty stable heart rate. And then at the end, once again, a pretty stable heart rate with it's the same before and after. So it's a bit suspicious. So let's have a look at the tracing. So here we can see the vSense marker on every beat, and then you can clearly see a gradual decrease in the amplitude of the R wave. And then here you have on the tracing what should be the R wave. So this is clear under sensing of the R wave. And then you have the marker 80. This is for asystole detected. So the device classes this episode as pause. And then after, when you have 12 consecutive VS, you have here the end of the episode. So this is a false positive that we see occasionally. It has been improved once again with the use of smart filtering, but improvements are still needed, and we're expecting improvements on the newer platform as well. All right, so now we'll review a tachy episode. All right, so on the graph, you have a pretty stable heart rate with a non-sustained acceleration. And then here, sudden onset, fast cycles, detection by the device. And here also at the end, you have very fast cycles that we could maybe think that these are non-physiologic cycles when we see at these rates. So let's have a look at the tracing. So this was from a patient implanted for ischemic cardiomyopathy, and he had an EF of 55% and had palpitation at follow-up. So that's why Reveal was implanted. All right. So when we look at the tracing, we have clear normal sinus rhythm with a P wave before each QRS. And then we have a sudden onset of a wide complex tachycardia with a marker TS. And then we have TD for tachycardia detected. And then we have and then it ends spontaneously. And the very fast cycles that we've seen on the graph corresponds to this one labeled as FS. So these cycles probably corresponds to the moment where the patient has lost consciousness. It's not rare to see these kinds of artifacts on the tracings when the patient have syncope, and it could correspond to a moment where the patient had a seizure. All right, so another tracing, we still have 2 left to do. So when we look at this tracing, it's labeled as tachy. It was in an asymptomatic patient. So we have a very stable rhythm and then a cloud of dots with very fast cycles at almost 300 beats per minute. So this clearly looks like noise. So let's have a look at the tracing. So here you can see the patient's QRS that are marching through the saturation of the baseline with, well, this is not artifacts, but these are myopotentials, and that were probably related to a pocket that was a bit too large. We've seen that quite frequently with the older generation when they didn't have the insertion tool and the pocket was done manually. So this was much more frequent on the older generations, but now with the development of the insertion tool, we don't see this quite often. So yeah, myopotentials. And then one last tracing of a tachy episode. So we can see once again cycles that were very fast, up to 300 beats per minute. So once again, this decreased the likelihood of a real physiologic arrhythmia. So when we look at the tracing, we can see a pattern repetitive of very fast cycles with baseline saturation. and the FS markers. So as I told you earlier, there is another way to count tachy episodes with FastVT. So it's when you have 30 out of 40 cycles that are faster than 231 beats per minute. The counters of FastVT will be implemented. So this was a tracing in an asymptomatic patient that went in close contact with an electronic device that was not properly isolated. So this is electromagnetic interference. Do you have any questions on these tracings? No? All right. So if there is no questions, I think we'll end the session here. All right, and we'll see you next week. So we'll probably discuss once again implantable cardiac monitors, but we'll do the Abbott platform next week. All right, so have a good day. Bye-bye.